Today we'll look at bipolar disorder briefly. My name is Dr. Peter Boakye-Boama, medical doctor and a resident in the psychiatry department, Kumasi, Ghana. My email is peterboakye27@gmail.com. Outline of the presentation: 1. Definition. 2. Etiology and epidemiology. 3. Pathophysiology. 4. Types. 5. Diagnostic criteria. 6. Signs and symptoms. 7. Investigations. 8. Complications. 9. Treatment. And finally 10. The prognosis. Definition: bipolar disorder, previously known as manic depression, is a mental disorder characterized by periods of depression and periods of abnormally elevated mood which last from days to weeks and, in some cases, months. Bipolar disorder is characterized by episodes of mania and depression. Etiology and pathophysiology. The etiology or cause is unknown. Now, the pathophysiology. The pathophysiology of bipolar disorder is complex and is not fully understood, but it is believed to involve a combination of genetic, environmental, and neurobiological factors. These factors likely interact to disrupt brain structure and function, particularly in areas related to mood regulation, emotion, and cognition. Epidemiology. Bipolar disorder affects approximately 1 to 2.4% of the global population, with onset typically occurring in early adulthood, often between 15 and 19 years. The incidence of bipolar disorder is similar in men and women, as well as across different cultures and ethnic groups. The prevalence of bipolar 1 disorder in males and females is 1:1. The mean onset of bipolar 1 is around 18 years. For bipolar 1 disorder, the rate at which identical twins will have both bipolar disorder is around 40%, compared to as little as 5% in fraternal twins. The mean age of onset for bipolar 2 is in mid-20s. Now, the types of bipolar disorder. We have bipolar 1, made up of mania with or without depression. Bipolar 2, made up of hypomania and depression. Then mixed bipolar disorder, made up of simultaneous manic and depressive symptoms. There are other types of bipolar disorder like cyclothymia, rapid cycling, seasonal pattern, schizoaffective disorder, bipolar associated with substance use, and antidepressant-induced hypomania or mania. You can read on this slide further. Diagnostic criteria for bipolar disorder. The diagnostic criteria are a set of signs and symptoms internationally agreed to be diagnostic of bipolar disorder. For here, we are using ICD-10 criteria, which states that there must be 2 or more episodes. Then the core characteristics, which is the occurrence of at least 2 episodes, with at least one being hypomanic, manic, or mixed. There must also be complete recovery between episodes. The criteria for depression is as for unipolar depression. Now, the signs and symptoms of bipolar affective disorder. Bipolar affective disorder has signs and symptoms of mania, hypomania, and depression. That's the presentation. Let's look at mania. Its core symptoms are elation, decreased need for sleep, and increased energy. This episode must also be present for at least 1 week and cause significant impairment in social, occupational, and other areas of functioning. If it lasts for 4 days or more and there is hospitalization, it is still diagnosed as mania. The signs and symptoms of mania are elevated mood, irritability, increased energy and activity, racing thoughts, decreased need for sleep, increased talkativeness, reckless behavior, and grandiosity. You can read further for the explanations. Then the signs and symptoms of mania, we are continuing. We have hypomania, which is the second type. The core features are the same for mania, but it must be present for at least 4 consecutive days and be present for most of the day, nearly every day. Crucially, the symptoms must not be severe enough to cause marked social and occupational impairment or to necessitate hospitalization, and they must not be due to the direct physiological effects of a substance or a general medical condition. It's associated with increased productivity and creativity. The symptoms are the same for mania, just that they are milder. The third one is depression. The core features are low mood or depressed mood, low energy, and anhedonia. There must be presence of at least 2 weeks of persistent low mood or loss of interest or pleasure, plus at least 2 other symptoms like fatigue, sleep and appetite changes, feelings of worthlessness or difficulty concentrating. The other features are changes in sleep, changes in appetite and weight, feelings of worthlessness and guilt, and thoughts of death or suicide. Investigations in bipolar disorder. To begin with, a physical examination and medical history must be done. Blood tests such as CBC, LFT, RFT, and TFT can be done. TFT is specifically done to rule out hyperthyroidism. Additional investigations include substance abuse screening where a urine toxicology can be done, usually with urine. Then imaging, though not typically used to diagnose bipolar disorder, can also be done. This includes imaging like MRI and CT scan. We also have mood charting. Treatment of bipolar disorder. Treatment of bipolar disorder deals with the current presentation and the phases. The phases of bipolar disorder are bipolar affective disorder, current episode manic, bipolar affective disorder, current episode depressive, bipolar affective disorder, current episode mixed. It can also present with psychosis, can also present with rapid cycling, seasonality, catatonia, and when we are just doing prophylaxis. Treatment of bipolar disorder. We are continuing. Now, treatment of bipolar affective disorder, current episode manic. To begin with, antipsychotics such as olanzapine, quetiapine, risperidone, aripiprazole, and haloperidol can be used. Long-acting injectables such as zuclopentazole and haldol-decanoate can be used. Mood stabilizers like lithium and valproate can be given, and benzodiazepines like lorazepam or clonazepam can be used. Then we have psychotherapy. Now, bipolar affective disorder, current episode depressive. The mainstay of treatment is medication and psychotherapy. Mood stabilizers, that's the medications, include lithium and lamotrigine. It must be noted that lamotrigine is used for refractory bipolar depression. Antipsychotics like quetiapine or olanzapine fluoxetine combination (OFC) can be given. Then long-acting injectables like Depixol can also be given. We also have antidepressants which can be given, though they are not used alone but with other medication. An example of such antidepressants is fluoxetine. Then electroconvulsive therapy and psychotherapy. We now have bipolar affective disorder, current episode mixed. The mainstay of treatment is mood stabilizing medication, psychotherapy, and sometimes electroconvulsive therapy, ECT. Antidepressants are generally not recommended as they can worsen manic symptoms in bipolar affective disorder, current episode mixed. Mood stabilizers used to treat mixed bipolar include lithium, valproate, and lamotrigine. Then atypical antipsychotics like olanzapine and electroconvulsive therapy. If it presents with psychosis, which are usually delusions and hallucinations, an antipsychotic with mood stabilizing properties such as olanzapine and quetiapine is the first line. Okay, then you must admit if severe. You must consider ECT if severe and persistent. Then mood stabilizers to help regulate the mood, since it's a mood disorder, such as carbamazepine. Then psychotherapy can be used. If it presents with rapid cycling, mood stabilizers such as lithium, lamotrigine, and carbamazepine can be used. Then antipsychotics such as aripiprazole, olanzapine, and quetiapine. Then antidepressants like mirtazapine, venlafaxine, and SSRIs, even though they have little benefit, can be used. If bipolar disorder presents with catatonia, which is a disease with abnormal movements, behaviors, and withdrawals like refusal of food, then the occurrence of catatonic symptoms during a manic episode is called manic stupor. When it presents with catatonia, we must admit, give mood stabilizing antipsychotics like olanzapine and quetiapine, then benzodiazepines like lorazepam, and ECT can be done. For prophylaxis, which basically means giving medication to prevent future episodes of mania and depression, we give lithium, anticonvulsants, antipsychotics, combination therapy, antibiotics, and psychotherapy. Treatment options for bipolar disorder. We have lithium, then anticonvulsants like valproate, carbamazepine, lamotrigine, gabapentin, and topiramate. We also use atypical antipsychotics like olanzapine, quetiapine, risperidone, aripiprazole, and haloperidol. High-intensity light therapy can be used, and then ECT too can be done. Psychosocial management strategies. We can do psychoeducation, advise the patient to avoid sleep deprivation, avoid recreational drugs, maintain regular daily routines, involve family members in detecting early warning signs. CBT can be done and social workers can be involved. Complications of bipolar disorder. Biologically, it can lead to cognitive deficits like memory impairment. There can be acute changes in mood, which may have serious consequences like medical, social, and occupational, including suicide. Excess mortality from other medical conditions. There can be high risk behavior, which can lead to HIV infection. Family and professional relationships can also be destroyed. Then legal problems. Prognosis. This tells us how good or bad bipolar disorder will be in the long term. The good prognostic factors for bipolar disorder include 1. Shorter manic episode duration. 2. Later age of onset and fewer psychotic symptoms. 3. Few medical problems. 4. Social support, among others. Then prognosis. Poor prognosis factors such as early age of onset, rapid cycling, psychotic features, substance abuse, and a history of childhood trauma or abuse all make the future prognosis of bipolar to be bad. And then again, protect your mind, for it is your home. That's our usual saying. And I thank you very much. You can follow me, like me, or subscribe. Thank you very much.